Ang objectives nila, well set, well written, well documented, and up to the end of the project, they are there with us to document everything. And that's what we need, the data. Again, the data. Because our city mayor is embarking in a program. Just present to him the seriousness of the data that you have. Why do I need to act on that? And that is our city leadership governance program. That's what we learn. The very first thing that we learn, you must show a very objective data. Okay? And there is PhilHealth is a health inequity. And I have to define PhilHealth when I studied in UP, my master's. Dinidefine na yung health inequity that was 1994. Hanggang ngayon, ang hirap pa rin i-define ng health inequities. To me, there are so many programs in the government, TB, maternal. If any one of these clients of ours, shall we say, is not satisfied with the delivery of our services, that is one health inequity. Therefore, 100% health inequities tayo. Because in all programs, ang daming amal, ang daming hindi natin nabibigay. And there is another one, I think that we also learned is, how do we bring the services really in front of our clients? So we really need to tell them that, kasi hindi nila alam yung iba talaga, there is reality that they don't know the services. Yeah. That's one. And they don't even know how PhilHealth works, the benefits of PhilHealth. That's why we are very thankful to one of our investors that this service excellence, as well as orienting all our health workers on the benefits of PhilHealth. Not even our health workers can recite the benefits of PhilHealth.
Okay, thank you very much, Dr. Actually,
Yes.
when I started in PhilHealth, we met with ULAP, the Union of Local Agencies, and we realized that many don't really understand PhilHealth, and we should really do more to educate them through IT, information technology.
I would like to add one, okay? In the primary health care, secondary care, tertiary care, in primary health care, let us have cultural transformation. I would say that hospitals is always a part of the primary health care. So, ito yung cultural transformation na sinasabi ko, let us not exempt the hospitals from the delivery of the primary health care services. So they have also to know what is happening at the primary health care level. That's one.
Okay.
So they must also know the programs in public health.
Yes.
So not all in our hospitals are public health experts. So kailangan may orientation din sila ng public health.
Okay, thank you, Dr.
Yes, thank you.
Okay, thank you. I'd like to ask the Secretary Ona. You heard the presentations today. You saw the roadmaps presented, the suggestions. What do you think, what else should be done, aside from what was already discussed?
I think there has been a long-term misconception about the healthcare system in the Philippines from the very start, maybe 50, 60, or 70 years ago. And that was the thought, or the belief, or even the practice, that the government will take care of the health of the poor and the private sector for those who are rich or who can afford. And that same thinking persists today. And that's exactly the reason why we have to jump to the issue or the concept of partnership with the private sector. When you're talking of primary health care, and you talk about the number of doctors in the public health system, that again is a concept that public health or primary health care is in the realm of government. Well, actually, you will not be able to do that without the private sector partnering with it. And that's exactly the whole gamut of what we did during the last 4.5 years that I was in the Department of Health, to make sure that people understand that when you are talking of a government hospital, or whether it is a private hospital, it should be able to cater to either the poor or the rich, because we have already what got up beyond the so-called concept of the old. It's the payer, bill health, that will be the major financial arm of the health system in the Philippines. And it will be eventually, in the future, the Department of Health that may give the direction, policies, and the implementers will either be government or private, whether it is in the primary health care or whether it is in the government, whether it is in the hospital care. And let government or the private sector compete. Isipan ninyo yun. Because to me, that's what the future will be.
Thank you, Secretary Ona. And finally, I'd like to hear from Karen. Karen is from the World Bank. What do you think, based on your experience around the world and seeing everybody else, other countries, what do you think what else can we do to improve equity, not just for the poor, huh? Because one of the things I noticed, and I've heard a lot of, is a lot of people pay for PhilHealth. The members, the ordinary workers, the clerks, the security guards, the regular employees. How come you keep giving so much to the poor who do not pay and not enough to us to actually pay? So that's also an inequity. Okay? It's too poor centered. What about the ordinary middle class? Where do they fit in? They're kind of feel neglected. So what can we do? That's a question always posed, and I understand and I agree. What about us?
The syntax reform. Of course, as we know, it's a sort of win for revenue to really increase the tax take by about 1% of GDP. Clearly also a win for health by reducing smoking rates, as we've seen in the graphs today. And also, very importantly, a win for good governance and a win for the poor. Right? By expanding health insurance coverage from 5.2 million families to 14.7 million families and eventually 15.3 million families, the government has effectively ensured guaranteed health services for half of the population and for the poor. And I think when you asked about what the lessons are from elsewhere in the world, well, this is a lesson from the Philippines for the rest of the world. The syntax reform has been demonstrational about how a committed health system, and in fact not just the health system, all of government, we've heard about the commitment to the health system, can really work together to achieve results for the poor. And I think as we move forward with the health agenda, one question we need to ask ourselves is whether this syntax reform, what it embodied, is this more than something that's just going to be demonstrational to the rest of the world, but can it also be transformational in the way we look at how we attack healthcare products? Will we continue to place the poor front and center in all of our decision making? I am not worried that our health system here, both our public and our private system, will address the needs of the middle classes. Our policymakers, as technocrats, your international experts, we're all middle class and above. We're implicitly taking that into consideration as we work. How to also ensure that the health system delivers for the poor. So I think if in all of these decisions that we are making as we move forward on the health agenda for 2016 to 2020, we ask at every step, what does this reform, what does this change mean for the poor? We will not be able to go far on. Perhaps if you just indulge me for 1 minute. We've heard about health system crises, the health workforce crisis. There is another crisis, and this crisis has been ignored today. In the Philippines, 1 in every 3 children is malnourished. stunting prevalence is 1 in 3 in a middle-income country like the Philippines. In terms of the number of children, the Philippines is in the top 10 in the world in terms of its stunting burden. So the challenge for everyone here is what are we going to do about this? And I think malnutrition is something that's indeed going to need, as Secretary Bruin said, a whole of government approach. It will require coordination across Department of Health, Department of Agriculture, Department of Interior, local government, and of course, full health and DILG, DBM, all the agencies we provide funding to the local level that can be used by LGUs to improve the nutrition status of their children. To me, that is an ignored crisis in the Philippines healthcare system. And we can move the needle on that. We measure malnutrition in our children at the age of 6, right? Our health agendas for the next 6 years. It is quite easy to commit to changing that and to see a measurable improvement within the period of our next health agenda.
Thank you, Karen. I'm afraid we've run out of time for any more questions or comments. Will I keep them on stage or will they go down? Would you like to stay on stage for the short explanation? Okay, so I think Mike wants to sit. Maybe you can sit down for your merienda. Yeah, please. Thank you very much. As we do that all of the